In patient care, there's this vital sign, a number you can't just see on a standard monitor, but it can be the single most important thing telling you if your patient is about to crash. So, let's get into it.
I mean, we've all been there, right? You've got a patient, their heart rate looks stable, maybe even textbook normal, but they are just circling the drain. You get that gut feeling that something is terribly wrong. So what's really happening behind the scenes?
Well, the key to that clinical puzzle isn't in the numbers we typically focus on. The answer is a hidden value, one that tells us what the heart is actually accomplishing with every single beat.
And that hidden number? It's called stroke volume. Seriously, just understanding this one concept can completely change how you assess a critical patient.
Okay, so what is it exactly? Put simply, stroke volume is the amount of blood your heart's main pumping chamber, the left ventricle, pushes out to the body every single time it contracts. You see, it's not about how fast the heart is beating, it's all about how effective each one of those beats truly is.
And to put a number on it, for a healthy adult who's just resting, we're talking about 70 to 80 milliliters of blood per beat. Just picture a small espresso shot of blood being sent out to perfuse the entire body with each contraction. That's our baseline.
But, and this is key, that 70 to 80 milliliters isn't some fixed number. It's dynamic, and it's controlled by three main factors. I like to think of them as the three levers you can pull to change the heart's output.
These levers are preload, contractility, and afterload. Preload is all about the filling, how much the ventricle stretches with blood right before it squeezes. Contractility is the raw power, how hard the heart muscle itself squeezes. And afterload is the resistance, the pressure the heart has to overcome to get that blood out.
Now, this is where it all comes together. To increase stroke volume, you can increase preload by giving fluids. You can boost contractility with medications. Or you can decrease afterload by opening up the blood vessels. And of course, the opposite is true. Lose fluid and preload drops. If the heart muscle is damaged, contractility falls. High blood pressure, that's increased afterload, making the heart work harder for a smaller result. Each of these levers has a direct, predictable effect.
Okay, let's connect this back to our mystery patient from the beginning. How does all this theory show up in the real world?
And here it is. This is the answer. When stroke volume starts to fall, the body sends out distress signals. You'll see a narrowing pulse pressure where the top and bottom blood pressure numbers get closer together. You'll see hypotension. And that normal heart rate from our mystery? It might start climbing as the body tries to compensate for each weak pump by pumping faster. This is your clue that the quality of each beat is failing.
Why does this matter? Because recognizing these signs of falling stroke volume is how you recognize the early stages of shock. It's how you decide if a patient needs fluids or vasopressors or a different intervention entirely. It moves you from just treating numbers to treating the underlying physiology.
So if you're going to remember just one thing from this explainer, one line for an exam or for your next shift, this is it. This is your money line. Stroke volume is about 70 to 80 milliliters per beat, and it's governed by preload, afterload, and contractility. Everything we've discussed boils down to this single powerful sentence.
So next time you see a patient who just doesn't look right despite what the monitor says, let this be the question that comes to mind. Stop looking only at the heart rate and start thinking about the hidden number that truly tells you what the heart is doing.